It's my pleasure to introduce Pat Snyder. She is a PhD and an RN and represents the Healthcare for All California. She's been working 14 years for single payer, the concept of having only one single provider. Her career has been in health and in hospitals and in teaching at the university level. This morning also, I got a notice that Bernie Sanders was introducing into the Senate a Medicare for All proposal, which seems to be at least getting some interest from the Senate. Maybe not all of them, probably not all of them. In any event, I think that it's really very, very timely that we spend this time and learn something about single payer. So I introduce Pat Snyder.
I have been involved with the League for many years, and for a period in the last decade was the healthcare consultant, legislative consultant for the healthcare program, and have just been spending many hours a week on this for, as I say, 14 years. It is my passion. I think it will solve enormous numbers of problems in our society if we are able to do this. The League, the California League, as you know, takes positions on policy issues. On our bill, SB 562, the position taken has been to support in concept, which is kind of a waffling until such time as the funding can be put into the bill. And as I go through my presentation, I will explain when that might happen and why it has not happened yet. But until it does, the League will not go further than that. So I can't really advise you about taking action, et cetera, except as individuals, not as League people. And I am speaking here as in an educational capacity rather than strictly an advocacy position with the League. Now, in regard to Senator Sanders' bill, I do know that there are 15 senators who are co-sponsoring, which is really quite a phenomenal number when a bill goes out like this. Last week, people were projecting 10, and we've got to 15, so that's really very exciting. So anyway, we're going to be talking about SB 562, which is a single-payer health care just for the state of California. Our idea is if we can do it in California with our population of 39 million, very similar to Canada's, we can prove to the nation that this is something that can be done and all Americans can ultimately profit from this. So, next. Sometimes you hear it called improved Medicare for all, but the system we're proposing is really quite different than the Medicare that you and I know. It would cover everyone, and it is a universal system, but there does not have some of the problems that Medicare, national Medicare, has. Anyway, the system, in general, a single-payer system is financed through a public system and pools revenues, including Medi-Cal and Medicare. In our case, it would reduce administrative costs, according to a recent study, from about 30% to 12%. And a lot of that would be accomplished by negotiating prices for prescription supplies and services. People talk about, oh, we'd be paying taxes, the taxes are too high, we don't need more taxes. However, that's all balanced out because everything people are currently paying for premiums, deductibles, co-pays, on, would go away and the taxes would substitute. And overall, everyone would save, except very high income people. So it would establish comprehensive coverage. Everyone would receive the same care. Right now, as you know, many people cannot access the same care, even if they have coverage, because their policies don't cover things. They have very high deductibles, and they can't meet the deductibles, and so they can't have the care, et cetera, et cetera. Under our plan, everyone would receive the same kind of care if they were in need of it. And there would be one card that could be used anywhere with any provider. Try again. There we are. Okay, this is just a title. Right now, we spend more than any other industrialized nation in the world per capita on our health care, and we get much less for it in terms of the quality of our health care. Again. I know that you can't read all of this, but it gives you a visualization of how we fit. Just look at the red. This is 2013 data, and it is out of date. We now spend more than $10,000 per capita on health care in this country. The red bar in the center is the OECD average, Organization of Economic Cooperation and Development. It is about half of the US. All of those countries to the left, as you're looking at it, pay more than the OECD average, but far less than the United States. And other countries around the world spend much less than the OECD average. Yes?
Could you point out Canada and France in that other graph? I'm just curious to see where they are. There's Canada.
Here's France, and here's Canada. Okay?
Thank you.
You're welcome. All right, this is just something to compare prices, us and others. Just a few selected countries. As you look across the bottom, what is average in 2013 again for a cost of very common procedures in the United States compared to other nations. So a bypass surgery in the United States on average would be about $75,000. In the Netherlands, it's 15. In Switzerland, 36. For an appendectomy in this country, it's 14,000. You can get that for 5 in the Netherlands or in Australia. An MRI, this is a big money maker for a lot of hospitals, etc. In this country, the average is $1,100, and in Australia, it's $350. What this is all about is our for-profit health system and the fact that people are charging way more than it costs to deliver services in order to develop a profit and also to pay the enormous administrative overhead that is integral to our system, that is built in because we have private insurance companies in our system. Okay, this is a little bit more, and I apologize, it's hard to read, but it's very dense data, and it really can't be presented very easily. Once again, across the bottom, you have the OECD median. This is for some basic health indicators, something about the health of our population. The first column is life expectancy at birth, and as you see, the OECD median is 81.2, and the United States is 78.1. Okay. France is 82.3, Canada is 81.5. So they're above the OECD median once again, and above us. Now the other thing I will say about this is that in our cities and in various places around the country, there is a dramatic difference in life expectancy depending on where you live. If you are affluent and live in an affluent area of a big city, my area, for instance, has a life expectancy of 85. 20 minutes away from me, the life expectancy is 77. And that's because poverty kills, of course, but in addition, our healthcare system does not provide the same level of care to people like me and people like those who are living in underprivileged areas, and that's not okay. Next, a column, no. Let me just say that the next column was infant mortality, and that is another place that our outcomes are disgraceful. Our outcomes are about twice as many infant deaths as the OECD median. And that is because we do not care for all of our mothers in pregnancy. And so they get into trouble, and so do their babies, and they lose them. Once again, this is inexcusable in a country that can do the kind of technological things in medicine that this one can do, but it's because we do not care for our people equally. Okay, here we have the just some of the hard facts about what people are paying these days and why many people cannot access health care, despite the fact that we had the ACA. There were still 28 million people left uninsured after the ACA was implemented. Family premiums for employer policies this at this point are $18,000 a year, and the employees are having to contribute more and more every year. You probably are aware of this. Deductibles have increased 67% since 2010. That prices a lot of people out of the market. That means they cannot access, they spend all their money on their premiums, and then when it comes time to actually get health care, they do not have the money to pay the deductibles. Underlined is shifted to patients. This is a concept you really need to grab hold of if you haven't already. What's happening with our private insurance is that the costs of providing health care are more and more. Insurance is supposed to take care of risk, right? That's why you get an insurance policy. But the risk is being shifted to the patients in the form of costs, so that more and more people are being asked to pay their own way despite having an insurance policy. The result of that is that 36% of them delay seeking care. This is insured people, and 35% have trouble paying medical bills. Okay, this is more on the same issue. You don't need to read all of the detail here. What it's showing you is that the ease or difficulty with which people are affording medical care, health care, is changing rapidly. From 2015 to 2017, people reported greater difficulty paying the cost of their health insurance. They reported greater difficulty paying for doctor's visits and prescription drugs. And they also reported having more difficulty paying the deductibles that are required before they can access care. And that's how it looks when in a different form. Let's see what we get next. Okay. This is a piece of why that's going on. This is shows you the difference in the growth of physicians and administrators from 1970 to 2009. See that little brown bar at the bottom? That's the growth in physicians, pretty much in keeping with population growth, maybe even below. But the growth in administrators is just skyrocketed. And with it, the black line goes our costs. And that's because the infrastructure that has to be created to support the insurance industry, both their bureaucracies and all of the bureaucracy that must be created in hospitals and in doctors' offices in order to manage the reimbursement, to check about authorizations, deductibles, blah, 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 blah. All of that stuff results in this, and this is what you're paying for. 30% of the premium dollars you spend for an insurance policy is spent on administration, not on health care. Okay, Dawn, next. All right. Just a few facts about the insurance industry and big pharma and why we think they need to change. $5.5 billion in profits since the AC was implemented for the 5 largest health insurance firms. That's a lot of profit. And the average insurance company CEO is $14 million. See, it's just incomprehensible. It just doesn't compute at all. Pharma has spent $1.6 billion lobbying Congress since the ACA was implemented. And now, and this I want to just be sure everybody understands, you hear that our drug costs are so high because we're paying so they can do R&D. Not true. They spend more money on marketing and sales than on R&D. Additionally, they spend their R&D dollars on things they think will be very profitable. They do not spend it on things just because they are badly needed. And there are a lot of replica drugs that have no purpose other than capturing market share. They provide no added value. Okay, next. Okay, now more about what we're planning to do. Right now, taxpayers pay 70% of all healthcare costs, and that's essentially the same for California and nationally. 69% nationally, 71% for California. That includes Medicare, Medicaid, cost of covering health care benefits for public employees, including teachers, et cetera, and the vets, everything, 70%. Insurance companies spend 20 to 30, as I've already mentioned, 20 to 30% of revenue on non-health related expenditures, including their profit and CEO salaries. Now, under Healthy California, which is the bill that we're talking about here in California, we would reduce those costs by consolidating the tax dollars, putting everything into one fund, a healthcare trust fund that was not part of the state budget, separate, isolated, and consolidating tax dollars there, which would lowering administrative costs because all of the complexity would go away. There would be one payer, and then negotiating directly with providers and prescription drug companies for the prices that are paid. Okay. So here are the key provisions of SB 562. One plan that guarantees health care to all California residents, everybody, including the undocumented, would save billions for workers, employers, the government, and as I've said repeatedly, no copays, premiums, deductibles, largely achieved by eliminating the waste that is part of the current system. People could go to the provider of their choice, no panels, no networks, none of that stuff, and decisions about care would be between doctors and providers, no authorizations, et cetera, et cetera. It would be based on medical standards of care, to the extent possible on evidence-based medicine, as it's called. Now, this next to last bullet, very, very important. Progressively based Healthy California premiums, that means people pay according to their ability, not according to a price set arbitrarily ahead of time, would fund an independent public authority that pays for the care. And I want to emphasize that public authority because all of the transparency laws, all of the open government laws, et cetera, would apply. And so we would be able to know why decisions are being made and how they are being made, and we don't know that now. The insurance companies do what they want to do, and there is very little that can be done to impact that or change that or even to know that. So that would be a big advantage of a government system. You could find out what was going on, and it would have comprehensive benefits that were the same for everybody. Okay, next. I'm not going to read over this. It's the benefits that are provided in the bill. Just point out a couple of things that would make a tremendous amount of difference to us that are very, very badly done now. Mental health, drug and alcohol rehab. Those are very hard to access for very many people now, but they would be covered. Another one that is often a great problem for people is in-home care for the disabled and the elderly, and that also would be provided. So pretty much anything you would require will be covered. Much more generous benefits than almost any plan at all, most generous insurance. Okay. Now, we're going to talk about the costs some and projecting about what all this would be like. We had a study done by Robert Paulin of UMass Amherst. He's nationally known. As a matter of fact, he's doing the study for Bernie Sanders' plan right now. So he's, in the big leagues. The PERI stands for Political Economic Research Institute, economic analysis. And the research group reported for us on a cost estimate of universal health care in California, the savings potential under Healthy California, how we could finance it. There were two plans included, one of which was much preferred, according to the researchers, and what the projected impact would be on businesses and families. And I have handouts that show that as that are sitting on the piano, as well as a handout that describes the plan. So, okay, next. All right, these are the numbers. In 2017, they projected that the cost of providing health care to California would be $368 billion, but would not include covering all of us. Now, you undoubtedly have heard that the plan costs $400 billion. That's been widely stated, and it's always phrased in terms of this is an impossibility. We couldn't possibly afford something like that, such an enormous sum. But right now, we're paying $368 billion and not covering all of our people. It would cost about $400 billion to cover all of our people under this current system. However, we're not going to do it that way. We have a new plan in place, the single-payer plan. And the estimated cost for the single-payer plan covering everyone is $331 billion. That's a 10% savings over current costs. And that's how, still covering everybody and saving 10%. So the next two issues, what would be available in California of tax money, presumed, would be $225 billion. That would leave a difference of $106 billion to be raised by new tax revenue. So the premiums, deductibles, copays would go away, and we would have taxes that would raise that $106 billion to fund the program. Okay, and this is the proposal that the researchers gave us. To get that $225 billion, current state and federal healthcare spending, to institute a 2.3% gross business receipts tax, exempting the first $2 billion. So that would mean that almost all small businesses would be exempt from paying any taxes into the plan. A business that gets $2 million in annual receipts is a pretty good sized billion and business, and that's when the taxation would begin. The rest of us would pay a 2.3% sales tax, exempting, like right now, housing, utilities, groceries, etc. And we would put in a tax credit for families currently on Medicare for that very low income group. So everyone would be paying something, but it would be an entirely different system than the current payroll tax supported business of some of our healthcare spending. So this is shows the savings for businesses. A small business that currently provides healthcare for its workers, we're defining it as 9 employees, would save 22% of their costs. So that would be a really big boost to the bottom line for those companies. Small businesses that do not provide health care would not benefit because it's a wash for them. And then it goes down with a larger business of maybe 19 having like 13%, 99 is more like 500 staff. Business would have about 6, and larger is very small amount of savings. But that would still be a big number. Okay, next. Okay. Yep. Okay, this is what would happen to households, families. There's a lot of data in the study, which is available online about, and this is just some examples pulled out. Can't put it all up here. I have a copy of the study with me if anybody is interested in looking at it. It's 84 pages. It's just packed with information. But it's much more accessible than you would think in terms of digging into it. Anyway, a middle-income family, saying $62,000 a year, would save 2.6 to 9.1%, depending on what kind of insurance they are currently paying for. And low incomes, meaning up to 35 a year, would save 1.2 to 5.5%, again, depending on how they were currently covered. High income people, meaning 227,000 or up, would see a slight rise of 0.6% of their average income, but that probably is affordable, so we're not going to worry about that. Okay, now this is just a little game. It's very much ballpark kind of thing, but if anybody wants to do it. If you figure your average monthly expense for taxable items and clothing, cleaning supplies, services, whatever. And if these cost you an average of $200 a month, that was the tax you paid, you multiplied that by 2.3%, you would pay $460 a month for health care. Now, I deliberately took an example that's very small because people worry greatly about the regressive aspects of a sales tax and what kind of a burden that would place on the poor. Not a great burden, actually. And given the fact that they would be able to access health care in a way that they cannot now, they would be gainers tremendously, because one of the biggest problems for the poor is health care. And actually, poor health and inability to find health care is a great producer of poverty, and is also, poor health is produced by poverty. It's a cyclical business, but the sales tax is not going to be a big burden for the poor.
Sorry, one question. Is there any sort of side effort going on, I know this isn't specifically health, related to taxing diapers? Because that could be particularly
I don't know anything about that. It's a good point. I know, I understand the idea about not taxing diapers, for goodness sakes, but I can't say that I can speak with any authority on that one. Okay, this is just what's happened to the bill since it was introduced in February. It passed the Health Committee in April, passed the Senate Appropriations Committee in May. The financial study was released at the end of May, and the Senate voted it out on June 2nd, 23-14. It is currently in the Assembly Rules Committee, where it is being held by Speaker Rendon. He complained that the bill was incomplete, but by holding it in the Rules Committee, he prevents us completing it. We can't do anything with it. Only when it is in a committee like Health can we add the amendments. And there are 17 of them ready to go in. And the funding was to be put in before the Assembly Appropriations Committee. But none of that work can go forward until the bill is sent to the Assembly Health Committee. Right now, it's stalled. We who are actively working on this, I also work with an organization called Healthcare for All California, and we have our representative from the nearest chapter to you in Aromas here. Thank you for coming. And we are very, very actively involved with a lot of other organizations, and I'll say a little bit about that in a minute, in trying to convince Speaker Rendon that it needs to go forward. Right now, we have a program in place, and it's going forward of having a legislative visit, a town hall, and canvassing in every assembly district in the state by the end of the year. And we are asking people to contact their representatives and say, move the bill. As I've said at the beginning, the League is not into action on this bill at this point. So I speak to you with that information strictly as individuals and not as League members, and you can take it from there. But we are working everywhere to get that moved forward. And I will also say we're getting wonderful responses at the doors when they do the door knocking. They're knocking on every door. They're not knocking on selected, registered voters of any party, and they're getting really, really strong support, which is very encouraging for the future. Okay. All right, this is a little bit about the campaign. It involves 350 organizations, which represent 6 million Californians, and it's made up of 4 different alliances that have come together. One is the Campaign for a Healthy California, which is 65 community organizations and unions led by the California Nurses Association, Labor Federation, immigrant communities, just a wide variety. And then an organization, All Care Alliance, which Healthcare for All belongs to, which is just single-payer groups. There are 3 organizations in the state of California whose sole mission is a single-payer system. One is my organization, Healthcare for All. Another is the Physicians for a National Health Program, California chapter. And the third is an organization that just does online work called California One Care. There is also a labor group in LA, 40 unions that are involved, and most recently a business alliance for a healthy California, which has, it's very new, but they're recruiting businesses very rapidly, and they currently have 140 businesses who are committed to advancing 562. They're growing daily, and if you know a business that might be interested, tell them to go online. You can find them easily. Okay, so I'm ready for your questions.
Are there any other states that are moving forward with this or who already have it in operation?
No, nobody has it in operation. New York has a bill that has passed its assembly 3 times and is within 1 vote of passing in its Senate, but it has 1 vote that isn't about to vote for it, 1 senator that isn't about to vote for it. But they keep at it. And there will be an election, and, you know, things may change. There are currently about half the states have a group of some sort working on single payer. And about half of those at one time or other has introduced a bill. But none of the only state that has ever passed a bill is California. And we have passed it twice back in the last decade, and Governor Schwarzenegger vetoed it both times. So we've come closest. And we're going to keep that up, but we don't have another state who is as close as we are. Now, one story I can tell you is that John Nichols, who writes in The Nation, if some of you may be familiar with him, spoke to the leadership group of the campaign last Friday. I'm a member of that group. And he emphasized strongly to us that what's going on in California is critically important to the nation getting single payer, because what's happening here is not lost on anybody, and the fact that our momentum is building constantly is noted. And we have some legislators fighting very hard against this, but they're still watching. And it was Bernie Sanders who put this on the political map with his campaign and now with his bill. And so there's a lot of momentum in the country, and the fact that we are as organized as we are and doing as much work as we are is having an impact all across the country. And he really emphasized how important it was to get it for everybody.
What about a sin tax like alcohol or cigarette tax versus a sales tax?
The tax has to be of a size that will generate the income necessary. The 2.3% gross business receipts tax would generate about $92 billion. And the remainder to get us to $14 billion could be raised by that small sales tax. And yes, this is the most common objection, and that's why I gave the example of what it would mean for someone who was not spending a lot of money on taxable items, that was really spending their income on necessities, would spend almost nothing on this sales tax. The other thing that I want to say to you is that the alternate plan for funding it was payroll taxes on employers and employees. That has the downside of it keeps our healthcare system attached to employment, which is one of our big problems. And if we can separate ourselves from that, if we can break that tie from employment, we're better off. But I have no idea what alcohol, cigarette taxes, et cetera, could generate. But that's the key to deciding whether a tax is something that we could use here. It has to generate a certain amount of money.
What will it take to get him to release the bill?
We think what it will take is grassroots pressure from the bottom up, and that's why we are doing this work in his districts, in all the districts, and particularly in his district. We've been canvassing in his district almost every weekend. Canvassing means his district. Oh, can't remember the number, it's down south. Bell, and some other, it's a very Latino district, and he is Latino. He has been very popular there. I'm sorry I can't remember some of the other cities. Should be able to. But we have been doing some polling there, and his support seems to be weakening. And we're doing our best to make it weaker. He's a speaker. It would take a resolution of the assembly, and they are not likely to do that because that's a very radical move. Very radical move. He is a very, very powerful man.
Has anyone considered making this a ballot issue?
Yes, in fact, there are people who are very strong proponents of single payer who advocate doing a ballot measure. But what we're thinking at this point is that that would probably cost $150 million, and we don't have it, and we don't know where to get it, because we're not Big Pharma. But they will throw tens of millions of dollars at us, no matter what. And we will have to have money similar in order to counteract what they will say when we are in doing a ballot measure. So one of the things that we're trying to do, we say it, we're trying to inoculate as much of the population as we can against their propaganda. I'm doing it today. I'm trying to convince you people of why we need this, and I hope you will talk to your friends. And that's what's going on with the canvassing, knocking on doors and giving people information and asking them to also act. It just seems like, how in the world can we ever do this with 39 million people? But it may be the only way to get it done. And we certainly are getting a lot more response than we used to. I said I've been at this for 14 years, so I was with it through all the Sheila Kuehl bills and the Mark Leno bills, and I saw how people reacted in groups and how people reacted just in general, and how many people were willing to get on board and work. It's just phenomenally different. It's just not the same thing. Yes, sir.
What if you have an insurance plan that you like? Will you have to switch to a single payer? What are other objections to single payer?
Yes, you would have, all the insurance plans would go away. You could self-pay a doctor who would accept that, but you would not have the same insurance plan. However, what we are proposing would be so much better than anything that's out there for insurance in terms of the benefits received and the cost you pay, that even though you might be very happy now, we think you'd be even happier. And that holds true, let me just say, for the Medicare population particularly. Medicare is very popular, and people say, this is one of the other objections. But think about it. 20% deductibles in many, for a lot of things you have to pay for Medicare. If you have a very expensive illness, that's a lot of money. If you need chemotherapy, that's a lot of money. Now, many people have a secondary policy that may pay most of ordinary Medicare costs, but you get to the point where you can be just bankrupted by the deductibles in Medicare. That goes away with our plan, and the Medicare population doesn't need to worry about that anymore. That's a big piece of why this is going to be good for everybody in our view. Yes.
What will happen to concierge doctors? Will California be invaded by seriously ill patients from states that don't have such a program?
This is always the worry with any social change. 8-hour day, minimum wage, everybody's going to come flocking. It has never happened. And think about it. They might want to move to California, but it takes more than a plane flight to move to California. The cost of housing is phenomenal. People who are sick can rarely leave their support system, and that would be involved. We're not really worried that we would be flooded with people moving into the state just to receive care when they suddenly got a diagnosis, because being able to do that is not really all that easy to do. Additionally, there will be a definition of residency that has to be met, and that's not totally worked out in the bill, but, that's, baby born is no problem, but for people moving in. And there are also provisions for people who have paid in, have been employees, have lived in California, but then are retired out of state. There will be coverage for them. There are provisions for payment for people who travel out of state, et cetera. And of course, people who come here and receive care, their insurer can be billed for that. Right. So there's lots of back and forth there. You've been trying and trying.
Well, I don't understand why pharmaceutical companies would oppose this, because they're still going to be selling all the drugs to all the people.
But not at anywhere near the same cost.
Okay.
Their profit. Why?
I mean, how do you keep it from being so expensive?
Well, we have a similar population to Canada. Canada negotiates its drug costs, and they pay way, way less than we do, so much less that many Americans mail order from Canada. Well, we'll negotiate with them too, and we're not going to take a worse deal than Canada. So they're going to come down because they can come down. The pharmaceutical industry comes in year after year, is one of the first or second most profitable industries. There's something sinful about that in my view.
Will I still be able to go to the doctors I go to now?
And I didn't answer the concierge question either, I just remember. Concierge doctors who charge a fee for a select group, they can continue to do that. Any doctor who wants to charge their patients directly can do that. And any patient who wants to pay full freight with any doctor can certainly do that. But the system will not be involved with concierge medicine. You can choose any doctor. There are no networks, no panels. Now, the one thing that you might call an exception is if you choose Kaiser, you choose that's what you've chosen. You are part of that system. You cannot use other doctors out of Kaiser, just as you cannot now, but you can choose Kaiser. If you do choose Kaiser, you have to stay with them for a year, and then you could move someplace else after that.
What about college students who go away to college in other states, or students from other states who come to college in California?
I don't think that has been addressed yet. I don't know the answer to that. Let me tell you this, which may help, though. With legislation, there are really two phases, and I'm sure there's lots of league people here who know that. There's a legislative phase, the bill is enacted, and then you move into the regulatory phase, and all the regulations that govern the implementation are enacted. So every detail is not in the bill. Some of those things get taken care of when we set up the regulations, and I would assume that that would be one of the things that would need to be addressed.
What has been reaction from the providers?
Nurses are greatly in favor of it. Physicians who provide primary care are also. And of course, there is the one national group, the Physicians for National Health Program, that is, its membership is devoted to this issue. And we have our chapter in California. As you move into the really super highly paid specialists, there is less and less enthusiasm for it. And that's just the way it is. But things like the American College of Physicians and Surgeons, which includes internists and primary care, family medicine, all that kind of thing, they've taken an official position in support of single payer, not necessarily of our bill because they're a national organization, but there is a great deal of support in the medical community. The California Medical Association is currently has a study group working on it, which is actually an enormous breakthrough to let them pay any attention to it, and we're very, very happy about that. So for providers, too, it appears that they're moving more and more in this direction. And what I've been told is the reason for this is that they are just so overwhelmed and sick of the bureaucracy that they must deal with in trying to care for their patients. It's really making their practice of medicine onerous to the extent that they would just like to stop it. And this looks like a way to do that. So there are many indicators that things are moving in our direction.
Will there be any sort of oversight regarding the kinds of treatment that is allowed?
No, there are standards about what can be provided. There are standards of care to be established. There is the whole issue of evidence-based medicine. That is a big value in the program. No, not anything anybody can dream of, any off-the-wall, experimental, whatever. No, it's not. No. There will be limits on that kind of thing, but generally accepted medical practice, no, there are no limits on that.
Once enacted, how long will it take for it to become operational?
It would be several years. It's not a light switch affair by any means, because the infrastructure has to be set up for that. And it will be a big switch. I don't know that anyone has actually done a guess about what would be included. In the bills we had back in the last decade, there was a 2-year window prescribed. This bill says that the program will not go into effect until there are sufficient funds in the fund to sustain the program going forward. So there are a number of issues that have to be taken into consideration and worked out. It's will be complex.
If a person has Medicare and Medigap insurance, how does that money get moved to the single-payer program?
We will apply for a waiver from the federal government to bring the Medicare funds to California. And let me tell you something else while I'm thinking about it. In the 1965 law that established Medicare, there was a provision that any state could elect to manage the Medicare dollars for their state themselves. No state has ever done that, but maybe we're going to be the first. So it's in law. And so we don't have to necessarily convince them that this is a good idea. We can just insist that they implement that provision of the Medicare law. So the funds flow into California. We, and I'm in the same position, we will not have to pay Part B, and we will not have to pay a supplemental policy. Now, Part D will be largely, drugs will largely be taken care of, but there is still some ambiguity about the Part D part of Medicare. So I'm not going to make any broad statements about that. But your Part B costs and your supplemental policy you will cease to pay for. And you will pay into the fund according to the taxes that are levied, which are almost certainly going to be less than you're paying for those things.
Is there any provision for extended nursing home or assisted living care?
The bill at this point provides for 100 days of assisted or skilled nursing after a hospitalization, just like Medicare. It also establishes a commission to explore extending coverage to long-term care, which is supposed to report back within 2 years of passage of the bill. But taking on long-term care at this point, as well as the rest of this, would be a big bite. And so we're not trying to do that right now. It's the dream to be fulfilled.
Will the level of service go down as we provide better coverage to those currently receiving little or no care, and as more of us reach an age where we require more care?
This is a very complex question you have asked, and there are a lot of factors that need to be talked about here. He was talking about the level of the quality of care would go down when everyone was cared for, basically. And there are a number of things I'd like to say about that. One, right now in California, we do not use all of our healthcare providers to the maximum we could. We do not use physician's assistants, nurse practitioners, et cetera, anywhere near to the extent that their education and abilities qualify them to do. And that is an economic issue for doctors. But under a program like this, we could change that and use those people much more effectively than we use them now. So we will not be, over time, we will not be working with the same provider group that we are working with now. Additionally, it will be much more attractive to become involved in providing medical care. There will be many, many jobs created. I'm not particularly worried about that because these countries, other countries, have better health outcomes than we do. Other people in other countries are provided with much better care than we are right now. Some of us get super, super good care, but not all of us. As we include everybody, you are right, there may be some strains in the system, but I think they are things that can settle out and will settle out, and because we will do things in different ways, and we will get the job done. I'm not worried about that at all myself. There was something else I was going to say about that, but it's flown. I'm sorry.
Will there be a provision for supplemental insurance?
No, we're not talking about supplemental insurance. We're talking about this one plan covering everybody for everything. That's what we're doing right now. We do not anticipate there will be a need for supplemental insurance. I remember what I was going to say to you. Every country except us covers everyone with the government program, but they do it in different ways. Ours is more nearly like Canada's than like France's. And the plan we are proposing. So what happens afterwards is not necessarily going to follow in exactly the same way the experience in some other country, because we're not proposing exactly the same thing. And as I say, I'm not concerned that the quality we are that is available to us is going to go down.
Just a comment on France. I believe France has been rated by the World Health Organization as having the best.
For quite a long while, it was #1 in the world. It isn't right now, but it was for a very long time. And that was because the health of their people was way, way up there.
Are both dental and vision care included in the program?
Yes, yes. This is one of the big advantages for most everybody, and particularly for Medicare, dental, vision, hearing, yeah.
How will physicians be paid? Will they get a salary?
No, not a salary. They will not be the employees of the state as they are in Britain, for instance. No. The provider system would remain private as it is now, except for exceptions like the vets, et cetera. But the providers would receive the same fee, and that would have a lot of implications, actually. The standard would be Medicare, which would provide them better than it does now, because they would not have all of the back office costs in their practice that they have now. The cost of their practice would go way down over what's happening right now, because all of that bureaucracy could go away. And the other part of it is that the physicians, for instance, who have large Medicaid populations, who are good enough to work in rural areas and in the low-income areas of our cities, and are largely treating Medicaid patients, their incomes would go way up, because they would be being paid on Medicare rates rather than Medicaid rates. So they would be in a much better place.
Will a layer of elite medicine emerge?
I'm not sure how big it would be, because it would have to be patients who were willing to pay full freight out of pocket. Now, I don't know how big that group is, but I don't. I don't think it's a big threat in terms, right now, we have many levels of medicine. We don't have one standard of care for all of us. Some people have nothing, and some people have everything. So we wouldn't be any worse off. I think we'd be much better off in terms of elite.
This is not a question, but to bear witness. In Taiwan in 1994, they went for universal health care. At that point, my nephew is at dialysis hospital. He owns that. So he was against it because he couldn't charge the same rate to go forward. But afterwards, he supported it because his business flourished. Instead of 20 patients, he has just lots of them. So by volume, it made up. So it will have to go with the same rate. All the elite, the specialists, they will go for the same rate, but they will get more patients.
Thank you all so much.
Thank you very, very much. Thank you.